Hello, welcome to today's ISNTD Connect on this lovely December day. It's a pleasure to see everyone connecting and joining us for today's session in collaboration with the Global Schistosomiasis Alliance. December is always a time for reflection, and thank you for making time in what is no doubt a rush to the end of the year. And also really great timing that this particular week is also the one that sees Universal Health Coverage Day, another day for reflection on extending healthcare to as many as possible, but also guiding, supporting, providing the evidence base to governments and health authorities to make really important investment decisions. What are the next steps? What are the next strategies? And so bringing kind of all of this together, it's a really wonderful time and timing to host this session. Welcome our wonderful speakers and all of the attendees that are joining fast our session today to have a think about schistosomiasis. What have been the many successes in the control, in the understanding, the in some cases elimination, but also what are the gaps remaining, what are the next steps, and what are some of the strategies that can really refine and underpin an acceleration and a very successful move towards improved control and hopefully elimination. We know the landscape for schistosomiasis is in some places very positive, lots of progress having been made, but in other places quite heterogeneous as well, with persistent reinfection pockets and so forth. So it's my pleasure to take a closer look at all these issues and share some very exciting research in this space to welcome our three speakers. I say three, although there's only two on screen right now, because our third speaker, Florence, I think you're in the audience. So I'm going to walk the tightrope of technology, and while speaking, I'm going to attempt to bring you on as a speaker rather than an attendee. If you can, click on the request to speak hand and I will immediately bring you on. I hope this works. So while Florence, you have a look at that, it's my pleasure to introduce our first two speakers. Dr. Steffi Knopp, welcome. It's really lovely to have you here today. You are representing the Swiss TPH, the Swiss Tropical and Public Health Institute in Basel, Switzerland. You are assistant professor there. Welcome to this session today. You've worked quite closely with our second speaker, Dr. Lydia Trippler. Lydia, welcome. You are now with the Lamberton Lab at the University of Glasgow. The project you will be talking about, SchistoBreak, was while you were at Swiss TPH as well, and we really look forward to hearing your learnings from there. And hopefully, on cue, to welcome you, Florence should be appearing on screen any minute now. All things going well. While the magic happens behind the scene, Florence, it's our pleasure to welcome you. You're representing the Ministry of Health Kenya, the Vector-Borne and Neglected Tropical Disease Department, and you are the Schistosomiasis and Soil Transmitted Helminthiasis Program Officer. I see an additional square any minute now. Hopefully we will see you. Florence, if you don't mind to refresh your page at the top of the screen, I think that will be the last step to having your video and your stream with us. Give that a few seconds. And while Florence connects, I can see that the Schisto family is very familiar with the Webinar Jam platform and how things work. Thank you so much. You've all been introducing yourselves in the chat, saying hello. Very warm welcome to you, Marianne, Florence, Yusuf, Joseph Adoyo from tuning in from Kenya, Govert Van Dam from LUMC, a big contingency there. Biran Mengistu Abdu from Ethiopia, welcome. Nicola Kashama from DRC. So very busy in the chat, and I hope you will continue to share your hellos, but also any questions and comments you may have for our speakers as we go through the session. Maybe sharing your questions, but also your own experiences and any thoughts you may have on the future of testing and treating strategies for schistosomiasis. So without any further delay, I'm going to hand over to you, Steffi. While we have your presentation, hopefully I can help Florence to get her video up and running. And we look forward to a really important, really timely and very interesting session. So without any further delay, over to you, Steffi, and welcome to everyone.
Okay. Yeah, thanks a lot, Marianne, for the introduction, and really great to see so many people, familiar people, new people in the chat that are here today with us. And I'm repeating what Marianne said, to reflect. So what I would like to reflect with you today is about schistosomiasis elimination and about optimal intervention strategies that we may have or may not have in low prevalence settings. So while there's a lot of familiar faces, I don't know if everyone is really familiar with schistosomiasis, so I just have a few slides about schistosomiasis to bring it into context. So if we talk about schistosomiasis, we are talking about a neglected tropical disease that is caused by a blood fluke of the genus Schistosome. And you see that on this picture here. Actually, the female and the male worm, they are mating, they are sitting in the blood vessels, they have sex, they produce eggs, and the eggs are causing the morbidity in humans. These parasites are transmitted in 78 countries globally. And there's about 800 million people at risk of infection. But of course, not everyone is infected. If you look at cases, that would be around 200 million cases globally. And the majority of these cases are located in sub-Saharan Africa, as we see on the map in the bottom right. The global burden that was estimated last in 2021 is about 8 million disability-adjusted life years for schistosomiasis alone. So that's a considerable burden. And if we go to the neglected tropical diseases as a whole, this burden will increase. And therefore, in 2015, in the Sustainable Development Goals, not schistosomiasis as such, but the neglected tropical diseases are mentioned in target 3.3 that says by 2030, we should end the epidemics of AIDS, tuberculosis, malaria, but also of neglected tropical diseases worldwide. And that suggestion has been also taken up or is reflected in the WHO NTD roadmap that was published in 2020 and sets goals for 2030. And these goals for schistosomiasis are to eliminate schistosomiasis as a public health problem globally, and in 25 among the 78 endemic countries to validate the absence of infection in humans. So these goals are quite ambitious, and we need to reach them. But how? This is also kind of indicated in the WHO guidelines on control and elimination that were published in 2022. Here, for low prevalence settings, and that means in settings with a prevalence below 10%, WHO suggests that where there has been a program of regular preventive chemotherapy, that we should continue that intervention at the same or reduce frequency. Or if it has not been in place, to use a test and treat approach. So that means either we continue with MDA or use test and treat, but whether we can really reach elimination with it, the evidence or certainty of evidence is really low. So I would like to ask you, what should be our goal? If we work in a setting below 10%, do we simply want to maintain low prevalence? Or do we really want to proceed towards interruption of transmission? And depending on that goal, what interventions do we need to reach these goals? And in my next few slides, I'm a bit provocative. So let's say we simply want to maintain low prevalence. Okay, if we want to maintain low prevalence, we have the option to really continue MDA at a reduced frequency, as suggested by WHO. But what would that mean? It would mean we treat people, prevalences go down, but not down to 0. And after a few months, they increase again. After 3 years, we would treat again, same, we go down low, we increase again. We wouldn't reach elimination, we just maintain the low prevalence. The good thing about this approach would be that the MDA systems are in place in most countries. With them, at least in schools, we reach good to excellent treatment coverage, and it would need to be done only every few years, so we could save some resources. But if we do MDA in a setting where we have 10% or less people infected, there would be a lot of overtreatment. And with MDA alone, we wouldn't prevent reinfection. Then let's move to the next point. Still, we only want to maintain low prevalence. The option 2 would be to implement a test and treat approach. How would we do that? It's not yet totally clear. We could either do continuous test and treating in health facilities and schools, I don't know where, or we could do annual big campaigns similar to MDA and do test and treat. In both cases, we would kind of keep the prevalence low, would probably still not get down to 0 and certainly not maintain 0. But with a test and treat approach, we wouldn't have a waste of drugs. We would probably have a moderate to good coverage, probably not as good as MDA because it's test and treat and it's a bit more complicated to implement. But the issue is we don't have the diagnostics yet to do it. The diagnostics we have for hematobium, point of care, hemastics in an elimination setting below 10%, are they really useful? The same for the POC-CAA. Can we really use it for test and treat? Open for discussion, I would say. And again, with the test and treat approach, we do not prevent reinfection. So again, let's get one step further from test and treat to surveillance response. And this is something Lydia will be talking in detail in her talk, in the next talk that we will see. So basically what she will be introducing and what we mean with surveillance response is that we would test children, for example, in schools, treat the positives, but then go one step further and also track them to home, test and treat there, track them to water bodies, test people at the water bodies, and importantly, also look at the snails and potentially implement snail control and involve finally also health facilities into passive surveillance. As you see on the right picture here, it's quite a complicated approach, this test, treat, test. I can't even say it. So there's a lot of effort. Again, the good thing is we are testing and treating in here, so there's no waste of drug. We would probably have a moderate to good coverage as for normal test and treat, and we would address reinfection because we're also looking at snails and we may kill the snails. But we still depend on the insensitive and unspecific diagnostics, so we probably have an undertreatment because we do not identify everyone. And as you will hear from Lydia, it will require new structures and a lot of coordination to implement. The final option, sorry, and that's Lydia will be talking about that, so I'm skipping that. The final option that we have is focal MDA. So we do focal MDA, not covering everyone, but just certain areas. And these areas may be the areas where we have a lot of water bodies that are indicated here in an example from Pemba Island in Zanzibar in blue. But in not all of these water bodies we find the intermediate host snails. We only find them in those areas with the dark blue dots. And as you will see, the human prevalence, the highest human prevalence indicated in red and yellow, is near these water bodies. And this is also what is reflected on the right graph. That is that people that live in close proximity to water bodies with snails have a much, much higher risk of infection than those that live anywhere. So we could really think about exploring in snail surveys where we find the intermediate host snails and then do focal MDAs in those areas around the water bodies. With that, again, we wouldn't have a waste of drugs. We would have a good coverage in those areas because they are small and can be really intensely targeted. We would also address reinfection because, of course, we don't only look at snails, we would also do snail control. But we need more effort for snail surveys and we need a molluscicide such as niclosamide. And finally, it will be really hard to find out about the denominator so that we know how many drugs we need and use. So those were my 4 suggestions for maintaining the low prevalence, from MDA over test and treat, over surveillance response to focal MDA. But they will all only maintain, they will not interrupt transmission. So now, what do we have in hand for interrupting transmission? If we go back to the WHO recommendation, it says, continue the intervention at the same or reduce frequency towards interruption of transmission. Well, we have seen that won't work, so we need more. But WHO also has another recommendation where it recommends WASH intervention, environmental interventions, and behavior change interventions to further reduce transmission. And this is what we will need for interrupting transmission. For interrupting transmission, we'll need to use everything we can with high coverage, and probably MDA has the best treatment coverage, higher than test and treat. Or surveillance response. And we will need to address reinfection with snake control through mollusciciding or environmental modification. We will also need to educate people so that they can change their behavior and practices. We need to provide or have people have better access to water and sanitation, and that will finally require socioeconomic development. And if we have managed to interrupt transmission, we will also need a good functioning surveillance response system to avoid reintroduction. So there's a lot we need for interrupting transmission, but it's quite worth going for that, because if we go and if we think about all the interventions that were just named, we are not only looking at the SDG number 3, good health and well-being, but we also look at reducing poverty, at clean water and sanitation, at quality education, at inequalities and gender equalities, and good partnerships. And that is just something to flag in terms of importance. Thank you for your attention.
Thank you so much, Steffi. That was really useful and lots of food for thought there in terms of the next steps. And so without any further delay, we're very eager to see what does this look like in the field. So Lydia, over to you with your insights from the Schistobreak project.
Thank you. I'm just going to share my screen.
Yep.
Can you quickly tell me if you see the slide?
Perfect. Thank you so much.
Okay, perfect. As Marianne has already introduced myself, my name is Lydia, and who might have come a bit later. I did my PhD with the Swiss CPH under the supervision of Steffi, who was just presented. I did stay a bit on as a postdoc to finish the project I'm going to present on today. And by now, I'm a postdoc fellow at the University of Glasgow with Poppy Lamberton. But today, I'm going to present on my PhD project, which was called Schistobreak and implemented in Pemba Island. And I'm going to present today on basically one of the things that Steffi has just presented as alternatives for MDA, so-called surveillance response, which includes a part of test and treat. So as Steffi already said, the WHO has those goals for all of the NTDs. And for schisto, it aims to eliminate schistosomiasis as a public health problem by 2030. But some areas in the world have already reached this goal and are actually already aiming for interruption of transmission, defined as 0 incident cases. And one of those areas are the Zanzibar Islands, Pemba and Unguja. And the project I'm talking about today, Schistobreak, was implemented in Pemba, so the northern one of those 2 islands. Pemba has a very long history of schistosoma hematobium prevalence assessments and intervention implementation. I'm particularly saying hematobium because there's no mentionai on the islands. And as you can see here, that by now the overall prevalence is super low, around 1%. And since 2017, Pemba has already reached elimination as a public health problem. However, what we also see is a highly spatial heterogeneity of prevalence on the island. So we have those areas here in green where the prevalence is super low down to 0 year by year. And we have those areas which are here presented more in like yellow to orange with a moderate to high prevalence. So now, knowing that we have this very low overall prevalence and even lower sometimes the prevalence in particular areas, is then to do MDA in all of the areas is really still justified? And if the answer is no, then what could be alternative interventions to MDA? And to answer this question, we implemented one alternative of those that Steffi has just presented in Pemba Island. And here you see a map of Pemba. We implemented the study in the northern part, here presented in green. And I'd just like to show you here, these are represent households with infected individuals that we found over the last 4 years. And I'd just like to show you that also here we have some pattern in the transmission, because if you look at where the water bodies with the intermediate host snails are and their density, then you see that there's very likely an association between the location of households with infected individuals and the location and density of water bodies with intermediate host snail. Other associations are socioeconomic status, rural versus urban areas, and so on. So in 2020, we started our schistobrick study, and we did annual cross-sectional parasitological surveys in schools and communities. And based on those surveys, we divided our study area into low prevalence and hotspot units. But our threshold was super, super low to declare something as a hotspot. And I know that in many other studies, they would not necessarily use the word hotspot for what we used it for. But I'm going to go with the word hotspot for this presentation. So everything that was a prevalence below 2% in communities or 3% in schools was a low prevalence unit. Everything higher was a hotspot. And we chose such a very low threshold because based on this threshold, we implemented different interventions. So in the hotspots, we had a multidisciplinary intervention approach. And in the low prevalence units, we had a surveillance response approach. What does this mean? This means that in hotspots, they received MDA in schools and communities once or twice a year. And we also implemented snail surveys and snail control with niclosamide whenever we found the intermediate host snail. And we had behavior change interventions in schools and communities. And now I'm coming to the part which is the really interesting part for today, and which is also the part that is really novel in the schistobrick study, which was the implementation of a surveillance response approach. So what did we do here? We went to schools, primary and Islamic schools, and tested hundreds and thousands of children. And only if we found a child positive did we treat this child with praziquantel. So there was no MDA happening in those areas. And then we asked this child, where do you live and which water body do you usually use, or which water bodies? And then we went there and offered testing and, if positive, treatment to the individuals in the households and at the water bodies. In those particular water bodies, we also searched for the intermediate host snail, and if we found it, then we applied niclosamide as a snail control to reduce the amount of intermediate host snails. And we also worked closely together with primary healthcare units, which, because of our study, were equipped with testing and treating material. So whenever they found somebody positive, they could treat this somebody with praziquantel as well. And I would like to go a step back to the surveys to run you through how we exactly did this all. So here you see each and every bar represents one school and their prevalence, and everything below the red line was considered a low prevalence unit. Everything above was considered a hotspot. The same was for the community survey. Everything below, low prevalence, everything above, hotspot. So in the very first year, this meant that we had 15 low prevalence implementation units. I just said we had 15 in the first year, and to run you through all of the years, we had 16 in the second, 17 in the third, And we just finished our last survey this year, where we then had 15 again. And every time between the parasociological surveys, we had the intervention period where we implemented surveillance response in low prevalence units, which would be all this here. So everything was orange, we did this. Everything in hotspots, we did MDA, snare control, and behavior change interventions. And let's have a look at the impact of the surveillance response interventions on the prevalence. So this is here the results of our school surveys. So you see a slightly decrease from the first to the second year, slightly increase from the second to the third, and a bit of a higher increase from third to fourth, and very similar in the community-based survey. And now you may say, well, but there's a bit of an up and down. Yes, but I'd just like to remind you that we're speaking about prevalences below 1%. So even if you see here up and down, these are still very minor changes. We did want to assess the sensitivity of this approach. So are we really able to find all the infected individuals living in the area with our approach? So we wanted to assess everything that is here on the right side of this figure, everything that you could also call test, treat, track, test, treat. So testing children in schools, following them up to their households and water bodies, and testing, and if positive, treating individuals there. So how did we assess the sensitivity? Well, you see here a bar graph where everything in yellow or orange is school-age children. In green, you have the adults. And we defined the sensitivity as the number of infected individuals observed by the surveillance response approach. So everything that is here shown in red, divided by the total number of true positive infected individuals living in the area. So everything here in blue. However, the blue number is actually unknown. So we estimated the number of truly positive individuals in the area based on the prevalence results from our annual cross-sectional surveys, together with the number of individuals living in the area, which was based on census projections. And we reached an overall sensitivity of 43.1%. However, this approach has a couple of limitations. One is due to ethical reasons, we always treated infected individuals after our surveys before the interventions. And as I just said, the number of estimated infected individuals was based on census projections, which means that all these numbers here might be overestimated, which might mean that our sensitivity is potentially underestimated. And although we are speaking about test and treat today, I didn't want to neglect that we also did snare control, which was part of our interventions. So I wanted to have a very short look at this. So this reactive snare control. And I just wanted to show you here that if you look at the third column, so the number of water bodies with bolinos, you see that we did manage to identify quite a number of water bodies infested with bolinos, because we asked the children, the infected children, where do you usually go swimming, playing, washing? And we did conduct snare control there. So we were able to really identify transmission sites by asking the children and accompanying them to the water bodies. And as a last slide, as a last result slide, I wanted to show you the timeliness of this approach. So starting with registration of children in the schools and testing them with 2 different diagnostic tests, to treating them, registering household members, registering individuals at water bodies, so including test and treat. This all took a median of 7 days. And if you include the snail survey and snail control, this ended up in a median of 16 days. So overall, it was quite timely. However, to do the surveillance response interventions in all of the low prevalence implementation units took around 6 to 7 months a year. So I'm coming to my conclusion. The conclusion is that the overall prevalence in the low prevalence units remained below 1%, but we did not accelerate further to interruption of transmission. But the prevalence also didn't go higher than 1%. I already said the sensitivity of the surveillance system was moderate, so it was only 43.1%, although it might have been underestimated. Many water bodies with bolinus were sprayed because we asked the children where they go for swimming and playing. So this identification of transmission sites worked very well. And the timeliness for the whole surveillance response system was very good. But now you may actually want to know if now this is a good thing to implement instead of MDA. And I must say it depends, and I think it's a very nice thing to discuss about. And I'm saying it depends because, well, let's have a look together at a couple of needs for MDA and test and treat. And then I'm sure maybe later we can have a discussion about this. So what do you need for MDA and test and treat to be successful? So for both of them, you need a very high coverage. For MDA, ideally over 75% as recommended by the WHO, but also for test and treat, if we don't have a high coverage, we are not going to identify the truly positive individuals living in the area. So it's super important to really find and identify the people who are tested positive. I think that's quite logical that for MDA, we need a lot more drugs than for test and treat, where you really target, test, and treat the individuals, whereas for MDA, you would treat everybody. Monitoring, what I mean with monitoring is that, for example, for test and treat, you really need somebody who has a very good overview on who has already been tested, who has been treated, did we follow up this child already, to the household, to the water bodies. So it needs a lot more organization, I think, than MDA. I'm not saying MDA doesn't need any organization. I know it does, but I do think that test and treat on a longer run just needs more. For MDA, unless you want to have a targeted MDA, you don't really need to know the prevalence of the area because you would just treat everybody. Whereas for test and treat, you really want to make sure that you're only implementing test and treat in low prevalence implementation areas. So you have to have a very good knowledge on the prevalence in your study area. And for both, you need a very high acceptability of the population. However, I must say that in Pemba, we have seen and also published that a lot of individuals would say, I'm feeling fine, I don't want to take the drugs. I don't see why I should take drugs if you haven't even tested me before. So they are not necessarily happy about MDA all the time. Whereas for test and treat, it's much easier to show somebody like, we have been testing you, we did find you were infected. Please take the drug to be cured. But last but not least, the thing that's the most important is that we need more sensitive and specific point of care tests. And I'm saying this because if we would have such a test, this would positively impact all these things that we need for test and treat. We could increase our coverage because we would actually identify the people who are truly positive. We would efficiently use the drugs. Our monitoring might potentially be a bit lower because we are not wasting time on false positive tested individuals. We get a much better understanding on the prevalence in the area. And if we would have a test, let's say like a pregnancy test, and we can show them on the point of care, see, you have been tested positive, I am pretty sure that the population would accept then being treated much more. And with this, I'd like to acknowledge a lot of people, particularly Steffi Knopp, who has presented before me, who was my PhD supervisor and has been leading this project. And then our whole team from the Public Health Laboratory Ivo de Caneri in Pemba, and the Ministry of Health in Zanzibar, and the Swiss National Science Foundation, which has funded this whole study. And all of you for listening. And should you want to get in touch with me at a later point, then you'll find here information on how to reach me. Thank you very much.
Thank you so much, Lydia. What a brilliant presentation. Should you move from MDA to surveillance response? It depends, you said, and you gave so much detail and so much thought all the way from challenges with MDA, all the way down to those community responses. So it's been really fascinating and an amazing piece of collaborative work. I hope you don't mind if I mention that if anyone wants to see a bit more of, color on what this research looked like in the field, that you are the star. A Star is Born, and your film, a documentary about work in this field in Pemba, is available. There's a very nice page on the Swiss TPH website where you can see and learn all about this film. I thought it was really informative and lovely, with lots of amazing testimonials. I've just put a link in the chat as well. And so while you were speaking, quite a few questions, fairly specific questions have come up in the chat, and maybe we could have a look at a couple of those while Florence hopefully connects, and I will attempt once again to bring you in from the audience, Florence, so I will just be there with you in 1 second. But here a quick question from Biran Mengistu Abdu, who says low prevalence measured by what? And presumably, Biran, maybe you'd like a bit more information about what those thresholds were or how you chose those metrics.
Sorry, what's the question on how it shows the threshold for whether it's hotspot or not?
So Biran's just asking low prevalence measured by what?
Low prevalence measured by based on urine filtration. Sorry, I think I haven't said this actually in my presentation. So we did those annual cross-sectional surveys in schools and in communities. We did assess for microhematuria and for urine filtration. So we counted X in the urine. However, the prevalence assessment, the threshold assessment was purely based on the urine filtration and not on the microhematuria. And that's then how we came to which area is below or above the threshold. I hope I answered this question now.
Yep, thank you so much. Another question, and lots of clapping and lots of very nice comments about both your amazing presentations coming through. Halata El-Bashir asks, what was the dose to use, 60 milligrams or 40 milligrams?
40.
Okay, super. And quite a few questions here around, what did you use to test children, adults? So how did you test the kids? Johanna Salfrank's asking, but also a bit more specific questions. Which test or RDT were you using for your surveillance from Tushabe Vianney? And also, how specific was the test which you used? And well, since we're on that, also based on your results, were you treating children and adults, or just focusing on one of the groups? Thank you.
Yeah.
There are lots of very practical questions here, drilling down into the work.
Yeah, so I really just realized that I should have talked about the diagnostics maybe a bit more in my presentation. So we did use, we did assess for microhematuria and urine filtration in the surveys, as I just said. We used the same diagnostics for the intervention, so for the test and treat, meaning that if we would go to the school, we asked them for their urine samples, and we tried to measure microhematuria on the spot, really, and if possible, already treat the children and ask them where they live and which water body they used on the same day. Although we did realize after a while that it was a bit complicated, to be honest, and it took a long time until we would have tested each and every urine for microhematuria. But yeah, so we did this ideally on the spot. We did it for sure on the spot in the households and at the water bodies. So we did test for microhematuria there. And then we took back the urine to the lab and did urine filtration there and counted X under the microscope. And if the children were tested positive, we went back to the school and gave them the drugs and then had the conversation with them about where they live, what water body they use, and so on. And if the adults were positive based on urine filtration and were not yet treated based on microhematuria, then we would call them and either ask them to meet with us in a central place in the village to get the drugs, or we would advise them, if that was easier for them, to go to a health facility that we've been working with, so we knew they had the drugs, so they could receive the drugs there. Yeah.
Brilliant. Thank you so much. You're being, given lots of questions here. And so maybe this last one, while I still give a few moments to Florence or perhaps Alison from the End Fund to request to speak, and then we will have you on for the final presentation. So just in the meantime, a very last question here from Juliet Chami, asking about, so what was the diagnostic, been through that, and also was census sampling of schools, how was census sampling of schools completed, and how was sampling in health centers performed? Did you have a set time period, all patients, systematic sampling, etc.?
Well, I think the diagnostic I answered now. Yeah. I'm actually not quite sure what she means with census sampling. I just skipped to the next one and maybe we can come back to this. So the health centers, we invited them twice a year to come to the public health laboratory, and then we had a full day of meetings and discussions with each other. And we had always a training on how to use the Hema-6 to assess for microhematuria in the urine. Most of the primary healthcare units that we worked with did not have the means to do urine filtration. So we equipped them with reagent strips to test for microhematuria. And then they would take them back to their primary healthcare units. And we did a whole discussion on what are symptoms. And so they would watch out for symptoms of schistosomiasis in the patients that were coming in, potentially also for completely different things. Maybe they came in for something very different, but they would mention a symptom that would also fit to a schistosoma infection. And then the primary healthcare units could test. And then they also got praxiquantiles, so they could also treat. And then they reported this back to us. Yeah, and now, and we visited them every second week. So every second week, team members would drive to all the primary healthcare units in the area and see whether they still had enough testing and treating material, but also check how many people were tested positive. I hope this answers this question. And now I'm not quite sure what is the question about the census sampling.
Well, as we were speaking, Lydia, Florence has just joined the room. So I'm just going to take a quick break from the many, many questions coming on and hopefully welcome you, Florence. I hope you can hear us.
Yes, I can hear you. Are you able to hear me?
Absolutely. And so firstly, a huge apology. This is meant to be a relaxing, enriching experience, not a nightmare. So I really apologize. Thank you for your patience. And while sadly your video hasn't come through, we can hear you really well. So I'm hoping that we'll be able to have your presentation seamlessly from now moving forward.
Yeah, thank you. So my name is Florence Wakesho, and I work for the Ministry of Health under the vector-borne and neglected tropical disease. I coordinate schistosomiasis and cell-transmitted helminthiasis. So today I'll present to you work that we propose to do on test, treat, track, test, and treat, the 5T strategy. Schistosomiasis in Kenya is a public health problem, and in Kenya we've been able to do milestones in terms of developing strategic documents to enable us reach the break-in transmission elimination goal. So our master plan defines our elimination goal as an area where we prevalence of less than aims to achieve this by 2027. Within the break-in transmission strategy, one of the goals is really to have innovative approaches with the goal of interruption of transmission for schistosomiasis. So these two documents are also aligned with WHO guidelines, and especially the national guideline on universal health coverage. Through the support of the goal is really to sub national interruption of schistosomiasis and soil-transmitted helminthiasis. So within the Western region, these are the 4 counties, Kakamega, Bungoma, Vihiga, and Trans Nzoia. We conducted a granular mapping where we were able to identify at the ward level the endemicity at the ward level. So this data has been able to refine us to help us define areas where we need to treat and areas we can aim for transmission, and areas, of course, where we are not treating and just putting surveillance system in place. So within these 4 particular counties, the areas where you can see that there is a lot of heterogeneity among the particular wards. And the highest ward had at least 34% of schistosomiasis, with several wards, at least 55 wards, which had 0 prevalence. So with this heterogeneity, we've been able to see that at least 139 wards have been selected, or these are IUs at the ward level, which we conduct mass drug administration. Our entry point is 2% prevalence based on our breaking transmission strategy. We've been aiming to treat, of course, with the available medication, praziquantel, children who are at least 5 years and above. So the test and treat strategy is being implemented in Bungoma. Bungoma, as you can look at it, it has a different intensity and prevalence within the different wards. And we felt this is the right place that we could be able to select for our test and treat. The reason why we do that is because Kenya, as we are aiming to eliminate, we are looking for innovative strategies, and also based on WHO guidelines of areas where you're not supposed to treat at least 10% as it was presented. Kenya, we have taken the threshold a little bit lower to at least less than 2%, 2 or less than 2% where we do not treat during our mass drug administration, and especially within the deworming innovation fund areas. These are those 4 counties. So looking at the recommendation, there is need for us to have innovative strategies, which of course are cost effective, as it has been explained. Again, of course, in other communities where we have done a lot of mass drug administration and the threshold is becoming now less than 2%, we are seeing that there is a lot of community fatigue because of continuous treatment. And so, again, we also need sustainable approaches, which of course can be integrated within our health system. And this 5 test and treat approach, we envisage it to be one of our sustainable approaches where treatment can be done within the health facilities, as WHO recommends in the guideline. So the objective of our test, treat, track, test and treat strategy for schistosomiasis is really to determine the prevalence and intensity of specifically schistosoma mansoni, using the point of care circulating cathodic antigen, the POC-CCA tests, among the individuals in the villages. And these are areas that have very low prevalence of above 1% and less than 2%, and have by cattle cards. So I've been able to explain why our cutoff is at least 2%. These are areas that don't receive mass drug administration. So we have picked several wards in South and West Bukusu wards in Bumula sub-county for this approach. And then again, within the objective, we would want to determine the number of positive cases to the primary index found by tracking and testing the secondary cases in the FT approach. As I'll be able to show you the approach that we are having both at the school and the household approach, we'll be able to see at first, we'll be able to identify the primary index, and after interviewing and tracking after testing and tracking the positive cases, we'll be able to identify the secondary cases. And so here also we want just to see what are those additional number apart from what we got from the primary cases. Thirdly, we also want to assess the costs, the facilitating factors, and challenges of implementing the test and treat. This is important to us as a program because we are looking at eliminating of schistosomiasis, but we still understand that we still have community members who could be infected in those particular areas where we are not conducting mass drug administration. So to document lessons learned from piloting this test and treat for schisto, again, will be one of our main objectives of this study. So in our study design, as I had mentioned, we are first going to be looking at the primary indexed cases, and this will be able to identify the schools, purposefully identifying the schools, and within the schools, we are going to randomly select children who are at least 5 years and above to 14 years. And within, we'll have two platforms. In the second platform, we shall have health facility. And these are individuals who go to the facility for routine checkup and for other medications. So when they are within the facility, we are going to be able to enroll them for those who are interested with the test and treat. And these are individuals who are going to be above 5%. So in these two approaches, we'll be able to identify the secondary cases. And this will be really purposive sampling because these are going to be recommended or identified after interviewing the positive primary index cases. These are both from the school and from the health facility. And of course, the inclusion will be everybody who is above 5 years and above within the community setting will be enrolled in the test and treat. So for the sampling site, as I had mentioned, we are looking at 3 wards, and this is South Bukusu, West Bukusu, and West. One similarity is that they have above 1% and less than 2% prevalence, and they have not been part of our mass drug administration. For our sampling, we've been able to take a very convenient sample size of 1,200. This is the total for both areas in the whole study. And why we picked on this population being our target is because of the timelines that we have. We have a very short timeline to be able to conduct the study. Secondly, the resources available, and the time. Of course, I mentioned about the time frame. So again, now in every ward, as I had mentioned, now here we are going to be picking. The total size is 1,200, but in each we are going to be picking at least 600 sample size. For each sample size, we are also looking at having, if we see like 50% will be enrolled, that will be 300 per village in each of the study sites. The diagnostic technique that we'll want to employ is a more sensitive test, that is the POC-CCA, especially for the light S. Mansoni infections. And this has been proven to be more sensitive than cattle cuts, and so we plan to have this diagnostic technique in our test and treat. So of course it is less expensive. When I mean less expensive, I might be right or wrong, but these are things that we are going to explore and see. Is it really expensive? But what I mean from my angle at the moment, looking that you don't really need high tech laboratory to train or technicians. Cattle cuts, you really have to spend time training our technologists. Again, also within the facilities, this is not a normal routine test. So this being a rapid test, then it's also easy to deploy even at the facility level. Secondly, as we are going to be doing the secondary cases within the field setting, we find this rapid test to be easy to deploy. So I know there will be, and what we have been looking at, how do we score in terms of those who are positive and require treatment and those who are negative that probably might not require treatment. So for our positive index cases, so for the ones that the band would be traced as a result, then in the primary index case, they are not going to be treated. But any that will be above +1, +2, or +3, and probably I need to define this, as this is an RDT, so we are having the test and the control band. So if the test band is barely visible, that's where it is negative. And in our case, we shall not treat the individual if it is a primary case. But then again, if it is a secondary case, the individual is going to be treated. However, if the trace is either +1, which the test band is readily visible, but less intense than the control band, the individual is going to be treated in both arms. That is at the primary index and also the secondary index. Or these are the cases. And then if it is positive 2 and the band is equal to the control band, that means both at the primary and also the secondary cases, they are going to be treated. And again, if the band is more than the control band, both during the primary and the secondary cases, they'll all be treated with praziquantel. So again, why we excluded the primary index from TRACE is really to avoid any errors that have been observed or documented in other studies. So in our inclusion criteria, I mentioned that we are going to be looking at children who are above 5 to 14 years, and especially in the school setting. But then when it comes to the health facility level, we are going to have 5% and above, and not having a cap of 14. So 5 and inclusion of adults at the health facility level. So these are individuals who are going to be assent and whose parents are going to consent for their participation, and especially at the school entry. And then all participants willing to consent at the health facility level or even at the community level will be allowed to be part of the study. And then the participants must be residents in the study area for at least 6 months. So these are the approaches that we are looking at. And so for the day one, and especially because we are having 2 platforms that we are comparing, that is the school platform and the health facility platform. I'll start with the school platform. So in day one, at the school level, where we are identifying the primary cases, we shall enroll the children, and of course, having sought consent from the head teacher, who is going to give a written consent on behalf of all the children who are going to be part of the study. So we are looking at children who are either above or 5 or above 5 years to be enrolled. So for those who are going to test positive, sorry, I can see the slide has an error. For the children who are going to test positive, then the following day, the study team, together with the laboratory and the community healthcare worker, will go to their households and, of course, have a conversation with the family, the household members, and, of course, the head, seeking consent to treat that particular child. So once the child has been treated, the rest of the members will be requested whether they would want to be tested and treated. And after consent, then that will be done. But this one now we are looking at least 5 individuals per household. So in case the household has more than 10 individuals, we are only going to be concentrating with 5. We're going to randomly pick 5. And for those who have been randomly picked 5, again, also we are going to seek to identify those who associate with them or probably have a same common contact place, probably where they do watch activities and a common water pool area. Children who probably play in that particular contaminated or water source together. So this particular household will be identified. So the community health promoters, because we shall engage the community members, will again go identify within that particular area, ask them, talk to them about the study, and then ask them for consent to be tested and then again to be treated. So the difference in the health facility approach is that so I've seen that I really interchanged a little bit in my titles. Sorry for that confusion, but I'll try to just explain the health facility approach, which probably could be this one that I was trying to explain, but the headings were interchanged. Apologies for that. So in the health facility, the individual, of course, is going to be asked for consent, enrolled, and tested. If they are positive, they will be tested at the health facility. And the second day, the community health worker will, of course, be able to identify the household where they come from, and then interview them and ask also for their close relatives, friends, or community members where probably they use the same water pool, also to refer to those particular households. In those particular households, then again, also they're going to be explained about the study, enrolled, tested, and treated. I just wanted to, because of that confusion, just to bring clarity here. So in the school health approach, sorry for the heading, in the school approach, the testing will be done on day 1, but treatment will be done on day 2 after consent has been given by the parent. I think that is the only main difference we are having. Whereas in the health facility, testing and treatment is done on the first day, but follow-up is done on the second day, which is similar to the school health approach. I hope I will be able to clarify this. If there will be any questions thereafter, apologies for that. So again, within the study as a program, we are interested to know about the costing of this approach. Is it something that is feasible? Is it something that can be integrated within our health system? And so we are going to be able to analyze the costing analysis on this. And this is going to be done on a time-driven, activity-based costing approach, which is a centered approach where it looks at both direct and indirect costs. As we all discuss this, remember these are activities, and especially at the health facilities, there are some equipments that are co-shared costs that already are running within the facilities that are probably not being accrued because of the study costs, like salaries and all that. So within the activities, we're going to be looking at the end-to-end, including even the time spent to locate the secondary index, the time used to go to their households, the time used at the lab and all that. So when it comes to people and equipment, of course, we shall have human resource. Some of them are within the payroll of the government. Some of them, of course, we are going to be paying them allowances. So all these are going to be considered. The equipment, of course, we shall have some consumables, which we'll have bought, especially for this study, which include the POC-CCA tests, which are not within the facility, and other consumables that probably are not within the facility. So all these are going to be costed. And of course, within the facility, we have equipment that are just used generally for all the patients. So that also is going to be costed. So I've talked about the on-site direct cost. This involves the salaries and other costs that are within the normal delivery. So within the tests and treat approach for the ministry, and especially the NTD, as we are looking towards elimination, we would really want to explore and see which of these strategies is more feasible, because at the end of the day, we want to implement something that is simple, easily to be implemented. It is acceptable within the health facilities and also acceptable by the community members. It is reasonable in terms of time spent. It's something that can be integrated, and also the cost-effective part of it has been analyzed, because cost becomes an issue, and especially where now the levels of transmissions are very low. At times, investment by partners and government is not quite high. And so for us, we are looking at, can we be able to answer these questions within the study so that we can see the feasibility of integrating the test and treat approach in our program. I want to acknowledge EndFund and Comparet, and to be very specific, individuals who have highly contributed to this work, to the study that we are going to do is Alison from EndFund. We also have Stella from Comparet. We have Dr. Odere. We have Dr. Odere from Comparet. We have Wycliffe from NTD, and other stakeholders who have been part in the development process, which includes also Professor Abanas Kioko, who is a specialist in the costing area from University of Nairobi. So I wish to end my presentation from there and take up any questions that will be coming from the audience. Thank you.
Thank you so very much, Florence. I'm just going to echo the words here of Hala Tahar El-Bashir in the chat saying, thank you, Florence, very insightful, and certainly thank you for this really complementary and contrasting perspective from Kenya. It's been really informative and useful. It's great to learn from our neighbors. Dr. El-Bashir also saying the Blue Nile Health Project in Sudan was a success story. Around the water-associated diseases and the Blue Nile River. Prevalence of schisto was reduced from 53 to 10%. So thank you for those comments. Yeah, and just a really, really interesting perspective, drawing from similar and also very different areas across the two countries that our three speakers have shared with us. So for that, a really huge thank you. There's been a few more questions in the audience while you were speaking, and perhaps a few things to think about that really might help to define what might be the next steps and what might be the simplest route to implementing some of these really amazing strategies. So maybe I'll just welcome our speakers to come back on screen. And I'm really sorry, Florence, we weren't able to have your video, but we could hear you really well. So we thank you for that. And one of the points that's come up a couple times in the chat is around the financial aspects of test and treat. A question from Johannes Valtz asking if you could just provide a bit more detail on that. Akinola Oluwale is asking it would be good to look at the cost effectiveness of the two strategies compared to the need. And a comment here again around the financial aspect from Ogechukwu Aribodor saying even the POC-CCA schistosome antigen test is very expensive. There would be a need to do something about the availability and affordability of these diagnostic kits. I'm not sure who would like to start with a few insights, maybe pointing us to some work around that or things to consider. Perhaps Steffi, Lydia, you've answered a lot of questions already. Maybe Steffi, you had a few insights into that.
Yes, can you hear me?
Yeah.
Yeah, no, thank you very much for that question, which is of course not only important for those who are donating drugs, but also test developers and people, administrators and researchers, whoever is involved in for effective costs. I think it is a difficult one. I think MDA as such has quite high implementing costs in addition to the donated drug. But I find it very hard in terms of organizational aspects to compare MDA and the structures that are in place in big countries. The advantage really, in my opinion, about MDA is that we really get a good coverage in vet schools. And that is unbeatable, even if we wait. We will never get that coverage with just because tracking individuals is a different story than just treating everyone. And in terms of compliance, Lydia has also mentioned, yes, people may see their test result and then take the drug. But again, if the tests are not sensitive or specific, and we are under treating because we don't identify. So, and that all plays into cost effectiveness, I think. So I think it is quite hard to say something about cost effectiveness for test and treat for surveillance response as long as we don't have the diagnostics yet that really offer us a sensitive and good and specific coverage in that sense. And in terms of also, as Lydia mentioned, like the surveillance response or also test and treat, and Florence probably may agree, it needs a lot of communication between teams in tracking people, following up, sending snail teams, doing snail control. There are a lot of aspects, and it's not just 2 days where we do like a blanket MDA, but it is probably a whole of a year of having different teams collaborating, working together, and tracking people. So yeah, it will be really interesting what Kenya finds. But I think it is not only about drugs and tests, but it's really about the logistics behind it and finally the effectiveness.
Thank you. That's a really good point. Florence, you're bringing to the table the perspective of a Ministry of Health, but also collaborating with a very important and long-standing funder in the NTD space. What might be your thoughts on the financial aspects of test and treat versus MDA?
Yeah, thank you. Yeah, so that's an important question. So for several years, we've conducted mass drug administration, and it's very complex when you're treating the whole community vis-a-vis when you want to treat a smaller population. I'd say that mass drug administration comprises of many pieces of trainings and many healthcare workers being involved and social mobilization, and also the aspect of safety monitoring. So it has different many pieces that at times are underlooked, but contribute to the cost of mass drug administration. To my perspective, if we look at test and treat at the facility level, and probably if the testing component is not too expensive, these are the diagnostic kits, then I think test and treat could be much easier or cost effective. Because when the transmissions are very low, and I've seen that practically in Kenya, at times convincing even community members to come and take the medicines really to get to the treatment coverage becomes a very hard task that you really have to invest more on social mobilization, and those are costs appending to this. So my look at this is that once we are able to really determine, because from where I sit, I see test and treat to be probably much cheaper. I'm not very sure until we are able to explore this, but I find mass drug administration to be very cost effective. There's a lot of heavily investments in mass drug administration to certainly cost the test and treat.
Brilliant. Thank you so much. Lydia, would you like to add anything to this?
I think they have covered it very well. I think it's going to be great if Florence and her team can actually assess the costs. I think a lot of people have questions about it. And I think it would be great if we could get an answer to it. I agree with Steffi that in our project, it takes a lot more effort, I think, to do test and treat compared to MDA. But then MDA needs a lot more drugs and people to, distribute them. So I think, getting a final answer to what is more cost effective has so many different dimensions. But if we have an answer for this at some point, I think this would be really important.
Yeah. Brilliant. And of course, all of this being completely qualified by the outcomes and the results seen in the drop in infection. So thank you. Lots to think about. There's been a really nice question from Maurice Frank, actually, asking on a completely different note, did you have social scientists in your team or have you collaborated with social scientists? Noting the amount of community engagement and communication involved in this effort, how were your social science initiatives designed and tested? Did you have them on your teams? What did this look like? I'm sure when you were creating a film, a documentary, this involved a lot of different teams collaborating around a very acute public health problem. So what have been your experiences in this? Perhaps we can take again the order of speakers. Steffi, back to you.
I would say yes, social scientists are important, and they become more and more important again if it gets towards compliance and coverage and awareness, which is all needed for test and treat or surveillance response or MDA. So having people understand the importance of getting tested and treated, or of getting treated, and therefore needing to know that schistosomiasis also at low levels can cause big problems. That is really important. In terms of the projects, Lydia could answer that as well. For Schistobreak, we had social scientists and behavior change team on board, but they were more involved, or we had them more involved in hotspots, and that was a part Lydia was only briefly mentioning. So we distinguished between hotspots and low prevalence, and in hotspot we really wanted to reduce transmission, and therefore we blew everything what we had, including, we didn't blow health education, but we had a lot of health education and community engagement and these kind of things. And I think they did a big job and reached a lot of people. So it would be great to have that as well for test and treat campaigns or whatever. We didn't have it in Schistobreak for the surveillance response approach, but it would have been definitely good to have better awareness campaigns designed by social scientists.
Yeah. While we're on Schisto break, Lydia, would you like to add something to that?
Well, I think Steffi covered most of it. Maybe what we could add is that another PhD student of Steffi, Naomi, who I think I saw her in the attendance list. She did. It was a related project to Schisto break, but because there were some questions in the chat about our primary healthcare work, she did a study on assessing the needs in primary healthcare units. Where she did, focus group discussions and really tried to figure out what do those primary healthcare units need. Where she also found that there's lots of knowledge there, but we are lacking, good diagnostic methods and tools in these primary healthcare units, and most of the units also don't have access to drugs unless, in our area they did because they got them from the project, through the project in the long run through the Ministry of Health. But other than our area, the primary healthcare units didn't have Praxikonte. And so Naomi did a very nice social science study, really having these discussions with the primary healthcare workers, trying to figure out their needs. So we did have this part, but we didn't have it so much in the bigger surveillance response approach, as Steffi already said.
Got it. Thank you so much. Florence, would you have a perspective from Kenya to share with us?
Yes, so thank you. So for this particular study, I know the role of anthropologists or these social scientists becomes very important, and especially where the infection is very low, because most community members know that they are not sick. But in this particular study, what we are riding on is our community health strategy. This is part of the healthcare system to be able to identify. And I think lessons learned from this particular study will help us in the scale-up plan on how to be able to approach communities, because I know there will be a lot of feedback from the healthcare workers, because we'll have questionnaires, we'll have exit interviews, and probably some of these comments or inputs we're going to get now from the study. But then I'll just want to mention as the other presenters that anthropologists come in very handy, especially in low setting areas, and you want to do test and treat approach. Thank you.
Yes, thank you so much. That's a really important point to finish on. Just moving back to the testing part of test and treat, if this is going to be rolled out, and clearly there's a huge case for it, but again, this question about just really focusing more on the diagnostic side, tests can be very expensive. Ogechukwu Aribodor writes, urine filtration kits should be ideal, but my worry is that the kits are very costly. We've seen cases where there was no hematuria, but when we carried out the urine filtration test, we found schistosoma hematobium. I think there is the need to make this kit readily available and affordable too. And that's kind of a theme picked up by Emmanuel Agunloye, who says, I would have loved to add microhematuria analysis to my routine urine analysis, but how accessible is this kit? And more generally, Akinola Oluwole says, how readily available is the point of care in the endemic communities? So just kind of widening that discussion a little bit, particularly if test and treat is to be rolled out further, how can we improve on the access to the tools, the technology, maybe even the skills needed to ensure this is successful? Perhaps, Florence, you might have a Ministry of Health insight on this.
Yeah, thank you. I was struggling to get the button. So from the health perspective and from probably the government side, resources, again, also are very competitive. And again, when it comes, as I mentioned, low prevalence setting, it becomes even much more a problem. So the intention is to really have very defined resource mobilization activities really for the government to be able to invest in this, because investment in such kind of areas I know would require a lot of intentional advocacy to our leaders, and procurement especially, because the diagnostic kits required even at these facility levels are probably not readily available, because even praziquantel becomes really an issue, not even the testing, the diagnostic kits. So really saying that a lot of advocacy is required, especially in low endemic counties, for us to be able to have good surveillance system. But one thing I would want to mention is that strengthening the health system is key, because if we are able to do this and minimize some costs, and especially I'll be interested to see the costs analysis for this treatment at the facility level and the community level, it will help us to even advocate and be able to compare and show the effectiveness on test and treat and investment for this particular for test and treat. So the costing study in this element for us becomes very crucial, so that we can be able to advocate to our leaders on this approach.
Thank you very much, Florence. Lydia and Steffi, would you like to add to this?
Yes, can you hear me?
Yeah.
Okay, yeah, no, I was just picking again. I'm getting back to the coverage, and with this time to the throughput of point of care diagnostics. And I mean, currently there is no test kit for schistosomiasis. I think you can either do the catechats for Manson-I or the CCA, or the urine filtration, or the hemastics for hematobium. And the hemastics in an elimination setting don't make sense, because many people are just not having blood and urine anymore. Yeah. And the urine filtration or catechats includes microscopy, which means you probably have to bring back samples to the laboratory, or you have to bring the microscope to the fields, but your throughput will be relatively low. So again, with an MDA just distributing drugs, you can reach hundreds and thousands of people. You can cover easily a school, but with the tests that we have currently available, we really have an issue in covering a whole school per day, and then we have to track the positives. So doing that in large scale will be difficult, and will need a diagnostic test that gives immediate results and precise results if possible. Yep. And that is not yet there.
To be continued. It's coming. Lots of teams working on that, hopefully. Lydia, would you like to add anything to this?
No, I think you covered it all. Maybe just to the point, I don't know now who said it, with sometimes microhematuria might be negative, but then there are X found in urine filtration. We had this a lot as well. And I think it's even worse, as Steffi just said, in an elimination setting. But then you may have people who are infected who are not having X in the urine, even though they are actually positive. And I think what we really tried, in lack of a better sensitive and specific test, was just like using both of them all the time. And especially in our test and treat approach, really treating based on both results, trying to really, get as many true positive individuals as possible to treat them. But it was just because we were lacking something better.
Fair enough. Thank you. Well, we're coming up to the last few minutes of the webinar, so I think we have time for just one last question. And before we delve into that, just reminding all the attendees that Anouk Guvras from the Global Schistosomiasis Alliance has posted a huge amount of incredibly useful resources, research papers, the collection of published papers, from Schistobreak, also one on behavioral interventions on schistosomiasis-related knowledge, including, of course, the Kenya National Master Plan for Elimination of NTDs that Florence referenced earlier on. So and many more. So firstly, a huge thank you to Anouk, and also please don't forget to click on those before the webinar finishes. And so just to wrap things up, and of course, turn to the future, just a really nice and easy question here that was asked by Dr. Hala Taha El-Bashir. What about the effect of climate change? And perhaps we can just twist that a little bit, but when thinking of an intervention such as test and treat, are you already thinking about kind of how this might look or need to evolve in future, given huge forces like climate change, changing the landscape for schistosomiasis, or even other forces like migration? What do we need to think about looking to the future if test and treat were to be rolled out? I'm not sure who really wants to volunteer to go first on that one.
I mean, I can say maybe a little bit about it. I'm not sure how good I get the curve now to test and treat in this sense, but I think that and that's just now my personal opinion, because I think there is still a huge lack of research. Like, I think we need to have a lot more studies on the impact of climate change on, for example, the snails. But I personally think that climate change will have an impact. We just don't know exactly yet in which direction. Yeah. We already see that seasons are changing. We cannot rely so much anymore on this is exactly the month where we have rainy season and this is exactly the month where we don't. I think that's already changing, and I'm pretty convinced that this has an impact on the snails. And this may mean that maybe the snails become more uncomfortable in the future. Or it may mean that they may be even more comfortable. And I think there's just like a lack of research on in which direction is the transmission going, basically. Yeah.
Absolutely. And there's been actually on ISNTD Connect some really good presentations on what do we know so far exactly on this topic. So by all means, the little that we already know, do feel free to revisit it on our YouTube channel. Steffi, would you like to add to this?
Yeah, I can. No, I do agree. And I think, Marianne, you have mentioned that. So, I mean, climate change will change changing seasons will change contact with water. And contact with water, be it schisto-related or unrelated, may either increase or decrease, as Lydia has said, and probably both, depending where we go. And what we need remains is a good diagnostic test. Otherwise, you cannot do a test and treat if you want to go back to test and treat. But yes, climate change will need to be considered, be it for migrant or mobile populations, or for those that live in areas be it big dams that are increasing or decreasing, new water bodies, or areas that get dry and then just is gone. Fine. But probably that's will have too many other effects that are not as fine.
Absolutely. Florence, what are your thoughts on the future of test and treat, given huge forces that we are operating in?
Yeah, agreeing with what has been mentioned. For government, always we look at, is it feasible still to conduct it even in a setting where climate change has come in. So for me, I'm looking at where there is climate change, of course, the disease transmission changes. We might be able to see that probably there will be more cases within the facility or not. The healthcare workers, will they be able to accommodate all those probably patients for test and treat? Will the facility or the system be able to sustain that approach? So for me, I'm looking at feasibility of integrating test and treat even in climate change. So the dynamics is, I think it is known as at now, because test and treat again also is something very new to us, but exploring these studies will enable us probably to have the baseline and the reflection able to maneuver around because disease transmission is a lot of the posts.
I think the line was a little bit discontinued there, but I think we heard loud and clear really Florence's message that with transmission dynamics moving and changing and evolving over time, this is something that at the government level is being considered, and having really robust strategies like test and treat ready to be deployed will be really important, particularly if we see these unpredictable or new dynamics emerging in the future. So on that note, I think it's a good time to pause temporarily these really interesting, fascinating conversations. I'm sure the audience will join me in agreeing that we are very excited and looking forward to hearing a lot more about how and where the evidence comes in to support test and treat. And while we wait for that, we just really wanted to thank you again one last time for taking time out for this amazing webinar. It's been so informative. Alison, thank you. Well, Marianne, but Anouk, Steffi, Lydia, and Florence, a very interesting webinar. I couldn't agree more. Thank you to the audience. Lots of questions. I think it was very clear that this was a topic that elicited a lot of interest, a lot of questions. So unfortunately, drawing our session to a close, but it's been an absolute pleasure. And on that note, lots of thanks coming through on the chat, of course. And the last thing I have to do is to wish you very well to our three speakers. Thank you for your patience with some of the technical challenges. And we look forward to keeping in touch and hopefully having you back on screen very, very soon. But for now, a big thank you. And hopefully see you very soon. Oh, I was about to forget to mention next week, our 100th ISNTD Connect, unbelievably. In my mind, this is still a very new thing that was launched in lockdown, but of course, lockdown was nearly 5 years ago, coming up to that. So no presentations, just a nice cup of tea and a chance to discuss, hear your news and just have a little chat to celebrate this very small but very exciting landmark of the 100th Connect. It's been an amazing journey and very interesting to get to meet everyone. So please do join us. But in the meantime, all the best to our speakers, and let's hopefully keep in touch and catch up very soon. Thank you so much.
Thank you, Marianne and GSA, for inviting us and having us. And everyone for being in the audience.
Yep. Thank you so much. All the best.